Assalamu alaikum. This presentation is about basing the treatment of acute sore throat on the available evidence and guidelines. In this presentation, we shall go through questions like who should be taking the antibiotics, which antibiotic for sore throat, any alternatives in case of allergy or intolerance, and in what dosage and at what frequency, and for how long would the antibiotic courses be advised. We shall also cover the management of acute sore throat with steroids, discussing should steroids be considered for acute sore throat patients and whether this should be taken intramuscularly or by oral route, and whether steroids can be given in children and in a single or multiple doses. In addition, we shall go for the evidence for treating specific acute sore throat conditions, including infectious mononucleosis, scarlet fever, and peritonsillar abscess. Not all cases of sore throats would require antibiotics. In fact, less than a third of the cases of acute pharyngitis and tonsillitis would have a bacterial pathogens. And even then, most of these cases would self-resolve within a week without a need for antibiotics. All the guidelines would advise the use of antibiotics only in selected groups of patients. The selection would be determined by clinical scoring systems. But when antibiotics are used, they can be useful. A Cochrane systematic review of more than 12,000 patients had showed that the antibiotics can reduce the symptoms of sore throat, measured at day 3 and also at day 7 of the illness. It can also reduce the incidence of peritonsillar abscess and other suppurative complications of acute pharyngitis to about 1/3, and can reduce the non-suppurative complications like rheumatic fever to about 1/4 of patients not receiving antibiotics. And based on the results of this randomized controlled trial, the NICE 2023 advice was to use the antibiotics strategy as such. If the fever pain score of 0 or 1 or the central score of 0, 1, and 2, then there is low risk and patients are unlikely to benefit from the antibiotic. The low risk is below 20%, so there is no need for antibiotics. Patients should be offered advice on self-care and to come back if the condition is getting any worse. With a medium risk of between 30 and 50% of having a group A beta hemolytic strep, this is a fever pain score of 2 or 3, then the patient will be given a backup prescription, and with a high risk, either fever pain 4 or 5 or central score 3 and 4, then the patient will be given the immediate prescription for antibiotic. It also suggested, the NICE 2023, that other factors should be taken into account, like the possible complications of untreated strep hemolytic group A, particularly in areas where, for example, non-suppurative complications like rheumatic fever is quite high, the rates are quite high. Penicillin has been the antimicrobial agent of choice for the group A beta hemolytic strep and still recommended by the most guidelines. The important thing is that the minimal inhibitory concentration of penicillin for group A beta hemolytic strep and other organisms has not shown any increase over the last 5 decades. For 50 years and more, there has been no signs of developing resistance to penicillin in the treatment of acute pharyngitis caused by group A beta hemolytic strep. You will see that most trials that we are going to go through have compared the penicillin as a gold standard with a variety of other antibiotics, for example, cephalosporins. We'll be analyzing outcomes, mainly based on the numbers needed to treat for different antibiotics for an additional beneficial outcome compared to penicillin. And we'll be looking at things like time to symptomatic or clinical cure, microbiological cure, clinical relapse rate, safety and adverse reactions, and other issues like costs and antibiotic resistance. to answer the question of which antibiotic, and also if there is any good alternatives in case of allergy or intolerance to that gold standard, and at what dosage, what frequency in a 24 hours, and the course length of the antibiotic. The core message from the meta-analysis of the Cochrane 2023 is that there is no clinically important differences in the clinical outcomes, generally speaking, when different classes of antibiotics were compared to the gold standard, to the penicillin, in adults and in children. There would be few examples of some antibiotic classes showing better results than penicillin, either in adults or in children, in certain clinical outcomes. We'll go through them, but the general picture is this. There is no clinically important differences in the clinical outcomes between the antibiotic classes and penicillin. If the outcome of the comparison is analyzing the clinical relapse rate between cephalosporins and penicillin, you would see a significant difference. In adults, cephalosporin had a reduced clinical relapse rate compared to penicillin. In children, there is no difference between the two groups. The total showed some benefits using cephalosporin in reducing the clinical relapse. The numbers needed to treat for the whole group would be 50 patients, and for the adults it would be more than 33 patients. These 4 trials included more than 1,300 patients. The certainty level is low. In another meta-analysis, this time the outcome is the side effects and the safety. There was no significant differences between cephalosporins and penicillin. This same question of whether late generation antibiotics used for shorter periods could achieve results compared to longer courses of the gold standard, the penicillin, was addressed earlier by the Cochrane 2012, and it showed similar results in large trial, more than 13,000 patients. It showed that using the late generation antibiotics could achieve some beneficial clinical results, although very modest, like it would have less periods of fever, less by 1/3 of a day compared to the standard penicillin for 10 days, could also achieve control of the sore throat for half a day earlier compared to the penicillin 10 days, and lower risk of early clinical treatment failures. And there was, on the other hand, an increased risk of late bacteriological recurrences and the short duration late generation antibiotics treatment. Very clear significance here, indicating that in cases of recurrent sore throats and in areas of high rheumatic fever, the longer duration and the gold standard of penicillin for 10 days is superior to shorter duration with intense treatment. So, in conclusion, the Cochrane 2023 had showed that comparing cephalosporins and macrolides with penicillin had showed no clinically relevant differences in the symptoms resolution. There was low certainty evidence that in children, carbazepine is better than penicillin, is more effective for symptom resolution. It's unclear if any class of antibiotics was better at preventing serious late complications like rheumatic fever. And finally, in the context of preserving the antibiotics, given the results, penicillin remains a useful antibiotic in the treatment of group A beta hemolytic strep. This is also the same conclusion and position of the National Institute of Clinical Excellence in their report in 2023 on the choice of antibiotic for sore throat. They state that there is no major difference in the clinical effectiveness between the antibiotic classes, including penicillin, cephalosporins, macrolides, sulfonamides in adults and in children in the treatment of group A beta hemolytic strep positive sore throats. There was some statistically significant differences in some comparisons of the outcomes, like we have seen in the Cochrane meta-analysis, but the results, the absolute differences were small. There was no significant differences in the adverse events. A systematic review had earlier showed that a shorter course of late generation antibiotics, broader spectrum antibiotics including cephalosporins and macrolides, was associated with significantly more adverse events when compared to the classic 10-day course of phenoxymethyl penicillin. On the efficacy of the antibiotics, the NICE 2023 showed that the antibiotics were significantly effective in clearing the symptoms of more patients the third day and the seventh day compared to a placebo, patients taking a placebo. At day 3, more than half of the patients on the antibiotic group were symptom-free compared to just more than a third of the patients who were on a placebo. The numbers needed to treat would be about 6. At day 7, most of the patients would be expected to be symptom-free at day 7 anyway, but still on the clinically positive cases requiring antibiotics, more than 87% of the patients were symptom-free compared to 82 patients on the placebo group. The numbers needed to treat would be obviously higher here because of the small difference at 21 patients. So overall, antibiotics shortened the duration of symptoms by about 16 hours in the 7 days period. The NICE 2023 recommendation for the first choice oral antibiotics for adults would remain phenoxymethyl penicillin with a dosage of 2 grams a day, either divided like 500 milligrams 4 times or a gram twice a day for either 5 days. That's enough for symptomatic cure, but when bacteriological cure is needed, in case, for example, of recurrent sore throats or in areas in which rheumatic fever is still abundant, then a full 10-day course would give a better chance of microbiological cure. So that's the first choice. Alternatively, if there is a case of penicillin allergy or intolerance in patients who are not pregnant, then clarithromycin is the best alternative at a dosage of 250 to 500 milligrams twice a day for only 5 days. But if the patient is pregnant, erythromycin would be a better choice than clarithromycin. Are patients allergic to penicillin? This was estimated at about 11% in a retrospective review. But only a small fraction of these, only about 11% of those 11%, has a documented allergy experience and anaphylactic reaction. The incidence of true anaphylaxis has been reported at less than 1 in 10,000. And of course, history of atopic allergy, for example, asthma or eczema or hay fever, then the patients would have a higher risk of anaphylaxis to penicillin. Also, if there is a history of immediate hypersensitivity to penicillin, then patients may also react to cephalosporins and other beta-lactam antibiotics. Antibiotics in general would be associated with diarrhea in the area of between 2 to 25% of the cases. If the patient is allergic to penicillin, the best alternatives would be macrolides, but in some cases cephalosporins can be used, and if that's the case, a narrow spectrum rather than a wide spectrum cephalosporin should be opted for. The first choice for oral antibiotics in children and patients under the age of 18, according to NICE, would remain phenoxymethyl penicillin at reduced dosage. Between 1 and 11 months, the daily dosage would be 250 milligrams divided into 4 or 2 dosages. This would increase to half a gram in the group between 1 year and 5 years, and a gram between the age of 6 and 11 years, again either 4 times a day or twice a day, for either 5 days for clinical cure or 10 days for bacteriological cure. In the age group of 12 to 17 years, it's up to the adult dosage of 2 grams penicillin per day. The 5 days is enough for symptomatic cure, but bacteriological cure could only be achieved at a better level with a 10 days course. The alternative first choice for children and patients under the age of 18 would still be almost the same. Clarithromycin, like in adults, at a reduced dosage, and in those very small group of patients under 18 who would be pregnant, erythromycin would be the preferred choice. Amoxicillin is one of the fastest action oral antibiotics and is also more palatable for children. But NICE 2023 had noted the increasing risk of resistance to amoxicillin. This risk is greatest in the first month after use, but is detectable for up to a year. In addition, of course, the use of amoxicillin in cases with glandular fever or suspected glandular fever is not advisable at all because of the erythematous rashes and reaction. Therefore, the advice from NICE 2023 is that amoxicillin should be avoided, and ampicillin-based antibiotics, including co-amoxiclav, should be avoided as a first-line treatment in the cases of sore throat. The gold standard for the use of phenoxymethyl penicillin is 4 times daily dosages. NICE 2023 had looked on whether twice daily dosage would be as effective as 4 times daily dosage for the same daily dosage of 2 grams, for example, in an adult. The twice daily dosage would obviously have some advantages. It would support medicine's adherence for people who would find it difficult to take the dosage at 6-hourly intervals before food, such as children at school, for example. On the other hand, the levels of the phenoxymethyl penicillin would drop below the minimum inhibitory concentration if it has to wait for 12 hours on the twice daily dosage. But the NICE 2023 had noted that the streptococci are highly sensitive to the antibiotic and that the penetration of the antibiotic in the sore throat tissue is quite good. Therefore, even small concentrations of the antibiotic will still treat the infection, and the advice was that twice daily or 4 times daily dosages could be used, providing the same total daily dosage of, for example, 2 grams in the adults. For how long should you be using the penicillin? NICE 2023 had noted that using the phenoxymethyl penicillin for 5 to 7 days would have a significantly lower cure rates in terms of microbiological cure compared with the standard of 10 days. And there was no significant differences in the clinical cure and the control of the symptoms or the relapse rate, the recurrence rate. But in cases of recurrent infections or in areas where rheumatic fever incidence is still high, a 10-day course that is going to achieve a much better microbiological cure is still indicated. This will increase the likelihood of microbiological cure significantly. Corticosteroids has been widely used to reduce inflammatory reaction in many conditions, both locally as well as systemically. It has been tried to reduce upper aerodigestive tract inflammation, including inflammatory diseases in the lungs and in other parts of the upper respiratory tract like acute sinusitis or otitis media. And of course, we use it already for short-term relief of the symptoms of sore throat and throat swelling in glandular fever, infectious mononucleosis. This is the meta-analysis summarizing the results of the trials on complete resolution of pain at 24 hours. The outcome measure was the risk ratio, and this side it favors the corticosteroids and the other side favors the placebo. And you could see 2 subgroups, one for the oral corticosteroids and the other for the intramuscular corticosteroids. And you could see a clear reflection of an effect here. Corticosteroids was more effective in reducing pain than placebo in various degrees. Intramuscular injection is obviously more effective. The net effect is that those patients on corticosteroids have more chance of having complete cure at 24 hours, 2.4 times those who have only a placebo. And the main outcome was this: resolution of pain. In addition to any effects of the antibiotics and the analgesia on the pain score and the pain onset, steroids had actually worked. It increased the likelihood of complete resolution of pain at 24 hours by 2.4 times. 2.4 times patients on steroids have a chance of complete cure and resolution of pain compared to those who had not had the corticosteroids. And at 48 hours, the ratio is a little bit less. It's still 1.5 times that of a placebo. What is of significance here is that the numbers needed to treat to provide this effect are just 5 people. 5 people would need to be treated to prevent one person continuing to experience pain at 24 hours. Another question was this: would you provide the steroids intramuscularly or oral route? And 2 studies were directly comparing the results of the intramuscular and oral administration and found no differences between the 2 routes. But on subgroup analysis of some of the other trials, there was an indication that the intramuscular route would have a greater effect size in at least 2 things: the percentage of patients having complete pain resolution after 24 hours, and they will also start to feel the pain relief a bit earlier than those patients on oral corticosteroids. Of interest here is that this other secondary outcome, the onset of pain relief, was also noticed more in patients who have severe exudative bacterial pathogen positive sore throat. The more severe the sore throat, the more likely they would benefit from intramuscular injection. But the effect size did not reach significance in both these 2 factors. So the advice at the end was that oral corticosteroids may be more acceptable to patients and appear to be equally beneficial. Now the question here is, would you prescribe corticosteroids in children? And 2 trials, the Bullock and the Olympia, had attempted to answer this, but the trials had opposing findings. The earlier trial, the Bullock 2303, found no benefits of steroids on time to clinically significant pain relief or time to complete pain relief between the steroid and the placebo groups. On the other hand, the Olympia 2005 found that dexamethasone actually reduced the duration of sore throat, reduced the severity of the pain, and had an earlier onset of pain relief compared to the placebo. And because only 2 trials and the results were not consistent, further research is also needed in children before a recommendation about practice can be made. The same conclusion about the effect of steroids on sore throats in children was reached by the Scottish Intercollegiate Guidelines Network later in 2010. There were, by that date, 3 trials of varying quality of effectiveness, but the evidence was insufficient to support a recommendation in patients with acute glandular fever. That's something else. And with infectious mononucleosis requiring hospitalization, steroids may have a role when pain and swelling of the throat can threaten the airway, or when there is very severe dysphagia. The question here is, would you give a single or multiple doses of dexamethasone? And 2 trials had attempted to answer this, and again provided some inconsistent results. The Kuderman trial in 2005 showed a significant benefit of 2 days compared to 1 day of treatment, but failed to provide any supporting data. But it was in favor of multiple rather than single dose of steroids. And the following year, another trial found no difference in the outcome between 1 and 3 days courses of treatment. If a single dose is chosen, it's 10 milligrams of dexamethasone in adults, and in children above the age of 5 it should be 0.6 milligram per kilogram body weight. The international guidelines varies about whether to use corticosteroids routinely to treat sore throats or not. We have evidence now, some of them high quality, that steroids increase the chance of complete resolution of pain at 24 and 48 hours. It also reduces the severity of the pain and shortens the time to onset of pain relief. You would start to experience pain relief a bit earlier if you are on steroids. On the other hand, steroids are unlikely to reduce the recurrence or relapse of symptoms or reduce the number of days missed from school or work. And the harm seems unlikely because the adverse events are almost not recorded at all in the trials. And the other factor is that the treatment is inexpensive. And this is the final verdict. There is a weak recommendation for using corticosteroids, but it may be used in almost all patients with acute sore throat. Weak recommendation because of the modest reduction of patient symptoms and the some heterogeneity in the outcomes and the variability in the patient's preferences. May be used in almost all patients, children above the age of 5 and adults, severe sore throat in combination with antibiotics, and not severe sore throat maybe as a standalone medication, in patients who are on immediate antibiotics and those who receive deferred antibiotics, in patients who have viral or bacterial sore throat, and in patients who seek medical help in emergency settings or in a primary care clinic. We move now to the management of specific acute sore throat infections, covering the evidence-based management for infectious mononucleosis, scarlet fever, and peritonsillar abscess. The management in cases of infectious mononucleosis is primarily supportive and symptomatic. The illness would generally resolve within 2 weeks. It's important to avoid using any ampicillin-based antibiotics to avoid the florid maculopapular eruption. It's also very important to avoid any contact sports during the first 4 to 6 weeks, even in the absence of splenomegaly, to avoid the risk of splenic rupture. And in children, they should avoid using aspirin as analgesics and antipyretics because of the fear of developing Reye's syndrome, which is basically a disease of childhood and can cause encephalitis and fatty degeneration of certain viscera. The best analgesics would be paracetamol and ibuprofen, plus rest and ample fluids. Antiviral agents may be considered in the management of infectious mononucleosis, and acyclovir is the most commonly prescribed antiviral. In a meta-analysis of 5 randomized controlled trials of more than 300 patients who were treated with acyclovir, showed that the use of acyclovir is not justified for the treatment of mild to moderate cases of infectious mononucleosis, no much benefit. But if there is a severe form of the infection, especially when the patient requires, for example, corticosteroids, and in the high-risk complication groups or prolonged fatigue syndrome, then antiviral agent, the acyclovir, would be helpful in a dose between 600 and 800 milligrams orally a day, divided into 5 equal doses for between 7 and 10 days, or 10 milligrams kilogram body weight intravenously 8 hourly for 7 days. Any role for corticosteroids in the management of infectious mononucleosis? A Cochrane review concluded that there is insufficient data to support the use of steroids routinely in all for cases of infectious mononucleosis. It's indicated on perhaps most in cases who have acute or pending upper airway obstruction, but not in the routine cases that would usually self-limit within 2 weeks. The role of corticosteroids in managing complications is also not very clear, but there may be a role in immune-mediated anemia, thrombocytopenia, and interstitial nephritis. Prednisone, or dexamethasone may be used. Prednisone had been shown to reduce the length of the illness, but the main action for the steroids is the management of complications of the infectious mononucleosis, basically the airway obstruction, but also other immune-mediated forms of the disease, including aseptic meningitis, myocarditis, pericarditis, and thrombocytopenia. Any role for surgery in the form of acute tonsillectomy in the acute phase to relieve upper airway obstruction. Only very few reports on fairly small cohorts have been published in the past. And the main lines of management for upper airway obstruction in cases of infectious mononucleosis include corticosteroids or emergency intubation or tracheostomy. There are few reports of acute tonsillectomy, including this report on 25 patients. Some of them were on steroids, 15, and 10 were not, and the operation was done successfully, and there have been no complications for the tonsillectomy more than the usual complications of tonsillectomy in the usual setting. The authors suggested that it decreased the morbidity of recurrent tonsillitis after the infectious mononucleosis as well, and relieved the upper airway obstruction. Another small cohort of patients, 36 admissions of infectious mononucleosis over 5 years period in a single institute, and that these patients were treated initially with corticosteroids and did not respond well. And the authors concluded that acute tonsillectomy is an appropriate treatment option for the subgroup of patients who have upper airway obstruction and their symptoms and cannot be controlled by corticosteroids. Antibiotic treatment for scarlet fever is obligatory. The treatment would shorten the duration and the severity of the illness, on average by about 24 hours. It also would prevent the chances of non-suppurative complications of strep pyogenes like rheumatic fever or glomerulonephritis. This may not be an issue in the industrialized countries, but in many other countries, resource-poor countries where the incidence of acute rheumatic fever is high, this is an important issue. Treatment would also prevent the suppurative complications of the strep pyogenes, including things like Quinces, sinusitis, and otitis media. And what is important in scarlet fever is that the treatment would reduce the spread of the infection in this very contagious disease, so it would help in controlling the outbreak. Penicillin has been the mainstay for the treatment of strep pyogenes for few decades, more than 50 years. It continues to be recommended as the first-line treatment in clinical practice guidelines worldwide. It has an established record of safety and efficacy and low cost and narrow spectrum, and it has not developed any resistance over 50 years of use. The other very good choice will be amoxicillin because it's similarly effective, it acts very quickly and is preferred for longer half-life, especially in children. The longer half-life would help in giving the patients twice daily or even once daily doses if needed. It's the beta-lactam antibiotics that are preferred treatment for the group A beta hemolytic strep infections due to their efficacy, safety record, and the low cost. Cephalosporins may be used in case of a history of penicillin allergy, but macrolides is not a very good choice because of the resistance to the macrolide is fairly common, and also because they have greater adverse effects than penicillin. In addition to the antibiotics, the symptoms can be controlled by either paracetamol or ibuprofen and plenty of fluid replacement. Scarlet fever is a notifiable disease, should be notified, and centers of education like schools and nurseries should also be notified and encouraged to report such cases. There are 4 main lines. First is the needle aspiration of pus. Second is the incision and drainage of the abscess. Third is abscess tonsillectomy, either unilateral or bilateral tonsillectomy. And fourth is antibiotics. Often the use of needle aspiration or incision drainage is followed after some time, several weeks or so, by elective tonsillectomy. A UK national audit in 2002 showed that most of the UK consultants, like more than 60% of them, would start with the use of needle aspiration as the primary method of abscess drainage, compared with only 25% of the consultants who would prefer to start with incision and drainage straight away. If the needle aspiration fails, then half of the consultants would then perform the incision and drainage. The advantages of the needle aspiration are obvious. It's relatively pain-free, requires only a local anesthetic, significantly contributes to pain relief once the pus is aspirated. It's not associated with any significant complications, very safe procedure. But the problem is that it's less reliable in complete drainage of the pus, with this potentially predisposed to a higher risk of recurrence and delayed complications of the peritonsillar abscess. The needle aspiration procedure, if the patient is cooperative, he or she can hold the tongue depressor, preferably combined with a light source. A good suction should be available to prevent any aspiration of pus or bleeding, and a wide bore needle is used to penetrate the palatoglossus muscle into the abscess space. Several attempts in several directions would usually lead to almost complete drainage of the pus. The resolution rate is in the area of about 80%, and if it fails, it can be repeated again because it is safe and easy to do and inexpensive. But it requires patient cooperation, of course, and a Cochrane group study in 2016 pooled results of 10 different studies and showed that the recurrence rate after recurrence of the peritonsillar abscess after needle aspiration alone would be in the area of 23% compared with just 4% for the incision and drainage. The risk ratio is about 4 times for developing a recurrence with the needle aspiration method. A Quincy knife incision and drainage is usually used when the needle aspiration has failed because it's more painful than needle aspiration, and historically it was associated with some disastrous complications. You could see here an internal carotid artery aneurysm displacing the tonsil and mimicking a peritonsillar abscess. The procedure for a Quincy knife drainage should start with infiltration by a local anesthetic rather than just spraying the local anesthetic. This gives far superior pain control. The site of the incision should not be higher than the base of the uvula in the upper part of the peritonsillar space, and the incision should not extend beyond the palatoglossus lateral edge. The incision should just be 2 or 3 millimeters deep, and to do this you need a number 11 pointed blade, and it should be guarded. The blade tip should be guarded with a plastic sheath in there to avoid unnecessary penetration deeper into the abscess. Once the incision has been created, a forceps can be used to widen the incision and allows more free aspiration of the pus. This can be helped with irrigation. Some of the pus would need to be collected for a culture and sensitivity. The Cochrane review of the results of recurrence from needle aspiration versus incision and drainage showed clearly the superiority of the incision and drainage method over all the studies. There wasn't a single study which showed a better results for the aspiration, and the net results was clear with a risk factor of about 4 times for recurrences after needle aspiration compared with incision and drainage. Antibiotics would be required in all cases of peritonsillar abscesses. In the small group of patients who have just peritonsillar cellulitis, antibiotics alone may help in controlling the infection. But if there is pus requiring aspiration or incision and drainage, antibiotics would still be required to control the infection. Which antibiotics? A combination of benzyl penicillin and metronidazole for the anaerobes would be the preferred choice. If the patient is allergic to penicillin, then either erythromycin or clarithromycin can be used instead. There is some evidence that benzyl penicillin alone is effective, but considering the high rate of polymicrobial nature of the peritonsillar abscess, particularly in type 2 of the abscess where there are multiple organisms, and the addition of metronidazole is essential. The other line of medical treatment would be steroids in the form of a single dose of intravenous steroid in addition to the antibiotic therapy. And this has been on the rise recently after a randomized controlled trial showed that the steroids would significantly reduce the throat pain, the hospitalization time, the fever, and the trismus, and that there was no increased risk in the use of the steroids. The other less used line of treatment is abscess tonsillectomy. In children in whom cooperation is required for needle aspiration or incision and drainage, and if these patients require a general anesthetic for these procedures, then abscess tonsillectomy should also be considered. The other indications for abscess tonsillectomy include recurrent or failure to respond to the treatment by aspiration or incision and drainage, or multiple abscesses, like in this case, in which it may be difficult to evacuate the pus from all the loculi. The results are very good, and there are minimal additional morbidity. The operation would almost prevent recurrence completely. There are very few cases of peritonsillar abscesses in patients who had had tonsillectomy in the past. The reported cases were about a dozen cases or so worldwide. There is also no need for the delayed elective tonsillectomy, since the operation of the drainage of the abscess and the tonsillectomy would be combined. The dissection of the tonsil would be fairly easy because the peritonsillar space is now filled up with fluid, with the pus, so the capsule is almost lifted from its bed. If the patient would given a delayed elective tonsillectomy date, this area would have intense fibrosis and would make the dissection of the tonsil in the elective tonsillectomy quite difficult. Main concern with the hot tonsillectomy was the fear of postoperative hemorrhage from the inflamed tissues. The figures does not substantiate such a possibility. In fact, the rate of bleeding is about readmission in theater for arrest of bleeding is less than 1%, which is quite similar to the rate for ordinary tonsillectomy. So there is no statistically significant difference between adult abscess tonsillectomy and elective tonsillectomy. Interestingly, most of the bleeders was coming from the contralateral side, the side that did not have the abscess itself. The tissues were still inflamed on this side and perhaps more vascular, but there was no clear plane of cleavage like on the abscess side, and that's where most of the bleeders were found. The advantage of abscess tonsillectomy is fewer days of morbidity, and the recurrence rate is almost next to zero, and of course you don't have to consider elective tonsillectomy later. On the other hand, presence of trismus and the edema in the oropharynx would add to the intubation risks of the general anesthesia. There are still open questions about who should be offered the elective tonsillectomy operation after developing a peritonsillar abscess. Would it be to all patients after just one single episode, or patients who had at least 2 episodes or more than 2 episodes? The figures after tonsil conserving treatment by aspiration or incision and drainage showed a recurrence rate of about 11% within 5 years, and that may increase to about 22% within up to 35 years later on the ipsilateral side. So the numbers needed to treat would be between 5 and 10 patients for these quite significant rates of recurrence if aspiration or incision drainage alone are used. Probably 2 episodes of peritonsillar abscess would justify having the risks of an elective tonsillectomy. In addition, there would be a subset of patients who have a higher risk of recurrence, the age between 20 and less than 40, who have recurrent tonsillitis. These may be considered for the interval tonsillectomy, even if they don't have 2 episodes. A recurrence rate is very rare above the age of 40, so that shouldn't be an issue. The patients above the age of 40 should not be offered elective tonsillectomy. By this, we come to the end of this presentation on the management of acute sore throat based on the evidence. Assalamu alaikum.